Hello, and thank you for checking out FirstCallID Approach to Recurrent Urinary Tract Infections. My name is Paul Bunce, and I'm a specialist in adult infectious diseases and internal medicine. We'll be spending the next 10 minutes or so going over some of the key aspects of an ID consultation. If you haven't done so already, please check out our first session on how to do an infectious diseases consultation, which covers a lot of the basics of ID consultations in general, whereas this session really focuses on the specifics of patients with recurrent urinary tract infections. Also, the focus here is less on the acute presentation and management of patients with suspected urinary tract infection, but rather the evaluation of a patient with recurrent episodes, either between episodes or as an acute episode is resolving. Before we move forward, just a quick note that this content is for educational purposes only. Please refer to current guidelines and use professional judgment in clinical practice. And before we get started, just a few upfront considerations. The first is just to keep in mind that no two patients are the same, and this is especially true when it comes to recurrent urinary tract infections. There is no single spiel or story or universal cure that we can offer patients that is guaranteed to work for them. And so we really do need to take an individualized approach when we are assessing and managing patients with this problem. And so one of the things I try to maintain in my practice is to listen to my patients and their concerns, be open-minded as to what works for them and what they're willing to try, but also try to stay grounded in the evidence that supports our different management strategies. So here's a general overview of the components of our assessment of a patient with recurrent urinary tract infections. We'll want to start with the medical history, just so we understand the context and the patient's general health, as well as medications and comorbidities. We'll really want to characterize their symptoms and their course. Really finding out about each episode, how is it diagnosed, how is it managed, and what is the response to therapy. Physical examination is generally fairly focused when it comes to this problem and will depend on the setting we're in, and also whether or not the patient is being followed or co-managed by a provider with more experience in genital, urinary, or pelvic examinations. Investigations will help us understand the microbiology as well as imaging to evaluate for any structural or anatomic abnormalities. And then from this information, we'll provide our impression and recommendations to the primary care provider or the referring doctor. So we'll start with the medical history. And here I like to understand the patient's general health condition, comorbidities, or their medical issues, medications they're taking, and anything that will affect their immune status. And this is important because we want to get an appreciation for the background of the patient before we dive into the whole urinary tract infection story. We also want to be aware of any prior procedures that could have altered the voiding mechanics or introduced any multi-drug resistant pathogens. We'll want to be aware of any medications that can impact genital urinary tract functioning, such as causing urinary retention, or those that can cause symptoms that can mimic those of urinary tract infections. Allergies are important to recognize. Many patients have labels of medication or antibiotic allergies, and it's important to clarify these so that we know what are our options when it comes to treating infections when they arise. The second part is where we really focus the majority of our energy, and that's understanding the symptoms and the course of their urinary tract infection history. I'll often start with the question, tell me your story of urinary tract infections. Is this a relatively recent thing that's developed or something you've been dealing with for a number of months or years? I also like to get a sense of what their symptoms are, so I'll often ask explicitly, how do you know when you have a urinary tract infection? And for some people, it's really classic lower urinary tract symptoms, so frequency, urgency, dysuria. Patients may have intermittent gross hematuria, whereas other patients might have non-specific symptoms like feeling a sense of fullness or lower abdominal discomfort or malaise. So it's good to know what are the symptoms that are driving their presentations and how concordant are they with urinary tract infections and how specific are they for urinary tract infections. You also want to get a sense of their pattern of infections. So how often do they happen? Is there anything discernible that would be a trigger or aggravating factor? Sometimes these infections concur with the menstrual cycle. Anything the patient notices also decrease the frequency of infections in the past. How severe are the episodes? Are they things that are managed maybe with a short course of antibiotics or a trip to a walk-in clinic, or are they hospitalized? Have they ever had a complicated infection where they became bacteremic? Also like to know when they are treated, what is the treatment course, in terms of duration of therapy, what antibiotics do they use, and how quickly do they respond to therapy? It's not an absolute, but generally patients respond to antibiotics within the first 12 to 24 hours. Maybe not have complete resolution of symptoms, but when a patient says that they take antibiotics and the symptoms last for another 5 to 7 days, it does call into question whether the symptoms are truly associated with an acute bacterial cystitis. And in terms of strategies employed, I really here focus on, what have you tried in the past to lower the frequency of your urinary tract infections? And often by the time they're seeing me as an infectious disease consultant, they've trialed a number of different strategies, sometimes a whole list of things, both pharmacological and non-pharmacological, behavioral, and that type of thing. Also clarifying what's worked for the patient and what have they tried that didn't work, and how much they invest in a certain treatment path. Did they try a medication or a supplement just once or twice, or did they really try it for a reasonable period of time to find out that it wasn't effective for them? Physical examination is obviously important, a key part of our assessment. When it comes to seeing patients in the sort of non-acute setting, when you're evaluating for recurrent urinary tract infections, there's not a lot of things I specifically look for. I mean, a general examination is important. The general urinary examination, again, is often deferred in our clinic setting, depending on whether they are being seen or will be assessed by a specialist with more experience into general urinary tract problems, or being able to perform a pelvic examination. But it is important to consider that there are some visible or objective findings that we can see that can be helpful to look for other clues to non-infectious causes of recurrent urinary tract symptoms. The investigations really is a review of previous investigations when we're seeing the patient. So we'll look at routine blood work just as a screen. We'll check the renal function just in terms of dose of antimicrobials and whether there's any contraindication to certain antibiotics. Looking to see if they've had any imaging to rule out any evidence of obstruction or structural abnormalities, any evidence of nephrolithiasis. If possible, it's sometimes helpful to see if there's been any imaging to document the presence or absence of urinary retention, such as doing a post-void residual. If they've had any prior interventions, such as cystoscopy or specific urodynamic studies, that can also be helpful. And then personally, I will spend some time looking through the microbiology, really cataloging the urine cultures, their dates, their what organism was identified, and susceptibilities, to see if there's a trend or a pattern, whether it's the same organism over time, whether it's a whole array of different pathogens, or if you'll start to see sort of a progression of organisms that are a response to recurrent antibiotic exposures, so increasing drug resistance or maybe selection for resistant organisms. Alongside this, I'll also want to make sure that there's been STI testing, usually a urine NAAT, for gonorrhea and chlamydia as an alternative cause for lower urinary tract symptoms. Other things to think about is whether they've been screened for candidiasis as well. From all of this information, I'll provide my impression and recommendations. And at the start, I'll again try to define the clinical syndrome. And by this, I mean, is this a patient who's presenting with very classically defined or described recurrent cystitis or recurrent pyelonephritis? Or do they have recurrent lower urinary tract symptoms of uncertain etiology? Or do they have non-specific symptoms that are possibly attributable to UTI? And I'll be honest that often it's a combination of these, where some patients will have recurrent lower urinary tract symptoms and have intermittent urinary tract infections, but the two might not all be concordant, right? So they might have periods where they have discomfort, but it's actually not a UTI, or periods where they have a UTI and they have atypical symptoms. And so you want to try to at least put them into some category or place them in a category to help decide on our further investigations and management. We'll want to provide our assessment of the most likely reasons for their recurrences if there is something identifiable. Right, and so if there's something structural or something behavioral that we can sort of pin the problem, at least attribute part of the problem to, then that's helpful. And then from this, we'll outline a plan for additional investigations and whether or not additional referrals will be helpful. Often, one of the next steps is to refer for a urological assessment. I don't think this needs to be done for most of the patients, really. The point is to consider urologic assessment if there's an expectation that they may be able to find out any structural problems, any additional problems with the bladder or collecting system. And also I found that specialists in urology and urogynecology and these types of specialties are often they have much more in-depth or broader differential diagnosis for these types of lower urinary tract symptoms beyond infection and I'm not sure not infection. And so they can often be very helpful in coming up with a differential diagnosis and a management plan for these other non-infectious problems. When would I consider a urology referral? Patients who have had frequent recurrent pyelonephritis, if they have gross hematuria outside of the setting of infection or history of renal stones, if there's imaging that suggests either urinary obstruction or abnormal structural issues, males with recurrent urinary tract recurrent urinary tract infections to rule out prostatic disease, or any other concerns for obstruction. After this assessment, I'll offer a preliminary plan for management and prevention of future episodes. So usually what I'll suggest is conservative measures. If there's mild episodes, things like increased hydration, maybe try analgesics if they're systemically well. Ideally, they can obtain a urine culture to guide antibiotic therapy, but also having a list of preliminary options for antibiotics should they develop symptoms that they can't wait for the culture results to become available. And then I'll plan to follow up with them in a few months to reassess the efficacy of these strategies. And in general, I try to provide an outline for evaluation and management as opposed to assuming care for every recurrence, and I offer to co-manage patients with their primary care providers through this process. I'll also say that there's fairly good evidence that patients who are young, otherwise healthy, usually female, who have recurrent urinary tract infections are reasonably able to self-diagnose and self-initiate treatment for their infections. I think there's definitely evidence to support that process or that strategy. However, when we are seeing patients with recurrent urinary tract infections, I think it raises the bar a little bit about how comfortable we are with treating just on symptoms alone, and we're much more cautious about the ongoing or repetitive antibiotic exposure. So I am a bit more cautious and do like to have cultures available for these patients. Now, in terms of recommendations, this is something that actually is probably best dealt with some sort of patient information package or handout. But these are the types of things that I like to include in my discussions with patients, at least at the initial assessment, and then revisiting them in later visits. The first is really kind of like goodwill hunting. It's not your fault. Patients often feel responsible or are made to feel responsible for these problems, attributing to a lack of hygiene or other aspects of self-care. And almost always it's not that, or at least that might play a very small role in their recurrent infections. And so we can talk about hygiene issues, but really taking the blame off the patient and saying this is a situation that you're dealing with, and we'll try to work through it. I also try to give patients hope. They can have a phase where these are recurrent and very challenging, but usually you can at least improve their well-being and decrease the frequency of these episodes and make them more manageable. I try to educate, two other main teaching points. The first is that not all lower urinary tract symptoms are due to acute bacterial cystitis, meaning not all of these symptoms are situations where patients require a course of oral or systemic antibiotic or antibacterial therapy. The other is to really discuss the principle or the entity of asymptomatic bacteria in detail, just so they appreciate that a urine culture does not define a UTI, and also the fact that a urine culture after treatment is generally not recommended and can often confuse the story and lead to unnecessary antibiotic use. I'll offer some treatment guidance. I'll emphasize the importance of cultures at this phase. The value of a urinalysis is debatable, and I've seen some providers say it's absolutely useless and some say it's essential. I fall kind of in between, but it really is case by case. And I'll provide a sort of treatment ladder for antibiotics to sort of say, like, if there are symptoms, this is what I would use first line. These are some next level antibiotics that you can use, and this includes considerations such as spectrum of activity, safety, dosing sort of regimens, tolerability, those types of factors, cost, right? So you take all those factors into account to come up with a guidance of ladder of escalating antibiotics when people are going to be treating them. And offer some prevention advice. And, the specific details go beyond the scope of this presentation, just as these are evolving. But I do try to focus on evidence-based strategies. And then, as strategies have more or less evidence to support them, I really do take into consideration cost, right? And it's not just financial cost, but also time, energy, money, sort of cognitive efforts, right? So I try to minimize the burden of these strategies on patients as much as possible and stick with straightforward, less costly interventions. And the most commonly employed one is just increasing hydration or improving hydration, as that is evidence-based benefits, and also, again, low cost and low harm for the majority of patients. I will allow and support less robustly supported strategies with caveats. And so there's a number of strategies that, evidence is, inconsistent at best in terms of, supporting their efficacy. And, I don't love pushing these or trying to push these for patients, but I will say that, every person's different, and for some people these strategies might be beneficial. So when it comes to things like supplements or nutritional changes, dietary changes, probiotics, different types of topical therapies or cleaning supplies, like all these things, I can't say for sure if it's the right step for everyone, but for a given individual, I can at least support its use as long as it's not harmful, or at least counsel against harmful interventions. When all of these approaches fail, I will consider chronic antibiotic prophylaxis, but for me that's actually much later down the list of strategies. That's certainly not something I bring early on into the discussion, but it's nearly a last resort of options, and the issue there is that when patients are on sustained antibiotics, it changes the flora and shifts the flora that colonizes their body and most likely drives more resistant pathogens to make the next infection harder to treat. And most patients are appreciative of that approach, but there are, again, some situations where we will go down that route. The evidence does offer some support for it, but again, it has consequences that I'm trying to balance. After that, there are a couple of other sort of late stage strategies that I would never employ without discussion or co-management with, specialists in urology or urogynecology. Things like, bladder diversion, or like a suprapubic catheter, or indwelling antibiotic dwells, that type of thing. I generally don't pursue those, but we'll discuss those with the patients, with their other providers if they come up. So again, in summary, recurrent urinary tract infection is a common outpatient referral or a common medical problem. When I assess patients with this issue, I really focus on their general medical history, understand their medical history overall, try to understand their particular or unique pattern of infections and symptoms and how they evolve over time, what works for them, what doesn't work. I'll examine for looking for alternative causes of their symptoms and investigations to screen for any structural abnormalities, and reviewing the microbiology to help guide next therapies. And again, providing recommendations and plan as evidence-based or as much supported by solid evidence as we can, with some individualization and balance for the patient's own wishes and interests. Many resources exist on the topic of recurrent urinary tract infections. I think two that I'll just highlight. So a wiki guideline group consensus statement came out a couple of years ago that's published here. So guidelines for the prevention, diagnosis, and management of urinary tract infections in pediatrics and adults. And it's a very helpful review of the different strategies that are employed and gives a good sense of how robust or strong the evidence is to support various strategies. The second is a bit more forward-thinking. It's urinary tract infections, pathogenesis, host susceptibility, and emerging therapeutics. And the point here is that our management strategies for recurrent UTIs are somewhat limited and not completely effective. And hopefully there are new strategies that are coming down the line in the coming years that will allow us to offer our patients better care and better symptom relief from this very common and challenging problem. So that's all for now. I'm Dr. Paul Bunce. I want to thank you again for watching. Please share any feedback you have over the session or FirstCallID as a whole. If you find what we're doing here useful, please share with a friend or with a trainee. Take care.